Hi everyone, I'm Dr. Divya Shanthi and welcome to NEET PG Core Revision series. These series are structured, focused and exam oriented so that you can recall faster and more confidently in your exams. In today's session, we are going to break down the nerves of the lower limb into clear exam focused concepts. So let's get started. So when we talk about the nerves of the lower limb, there are few important nerves which we should know. So one of them is the femoral nerve. So the femoral nerve is the nerve of the anterior compartment of the thigh, which is otherwise called as the extensor compartment of the thigh. Then we have the obturator nerve, which is the nerve of the medial compartment or adductor compartment of the thigh. Posteriorly, we have the sciatic nerve, which is the nerve of the posterior compartment of the thigh, otherwise called as the flexor compartment of the thigh. Now when we come to the leg, the sciatic nerve will divide into two, that is the tibial nerve and the common peroneal nerve. So the tibial nerve, it forms the nerve of the posterior compartment or the flexor compartment of the leg. The common peroneal nerve will divide into superficial peroneal nerve and we have the deep peroneal nerve. So the superficial peroneal nerve will be supplying the lateral aspect or the lateral compartment of the leg, whereas the deep peroneal nerve will be supplying the nerve of the anterior compartment of the leg, which is otherwise called as the extensor compartment of the leg. In the foot, we have the deep peroneal nerve as well as the superficial peroneal nerve, which will be supplying the foot. And that is the dorsum of the foot. And in the sole of the foot, we have the medial and lateral plantar nerves, which will be supplying, which are the branches of the tibial nerve, and they will be supplying the sole of the foot. So let's get started with these nerves. So all of these nerves, they are the branches of lumbar plexus, which begin in the abdomen, abdominal cavity, and the sacral plexus, which begin in the pelvis. So when we see the first nerve, that is the femoral nerve here now, is formed by the posterior division of the ventral rami of L2, L3 and L4. So L2, L3, L4 posterior divisions, the posterior divisions of the ventral rami of L2, L3 and L4 join together to form the femoral nerve. Whereas the obturator nerve is formed by the anterior divisions of the ventral rami of L2, L3 and L4. So this is the femoral is by the posterior divisions, whereas this is by the anterior or the ventral divisions, anterior divisions of the ventral rami of L2, L3 and L4. The sciatic nerve is formed by the ventral rami of L4, L5, S1, S2 and S3. So all this join together to form the sciatic nerve. So the tibial component of the sciatic nerve is formed by all of them, that is the L4, L5, S1, S2 and S3, whereas the common peroneal component, which is otherwise also called as the fibular component, fibular part of the sciatic nerve, is formed by L4, L5, S1 and S2. Now let's first study the femoral nerve. Now the femoral nerve is the largest branch of the lumbar plexus. So it is formed by the posterior divisions of the ventral rami of L2, L3 and L4. So here if you see, it is formed by the posterior divisions of these posterior division of ventral rami of L2, L3 and L4 spinal nerves. So this nerve, it arises within the psoas major muscle. Now these lumbar plexus we see in the posterior abdominal wall. So there we have the psoas major muscle. So these nerves, the femoral nerve basically begins within the psoas major muscle. Within the psoas major muscle from these posterior divisions of ventral rami of L2, L3 and L4. So once it begins, it descends along that is through the psoas major and emerges along the lateral border of the psoas major and passes between the psoas major and the iliacus. And then it enters the thigh behind the inguinal ligament lateral to the femoral sheath. So this femoral nerve, you have to remember that it lies outside the femoral sheath. Now in the femoral triangle, so here it will enter. So this is the portion where it will enter the inguinal ligament. Now this has a very short course. The femoral nerve has a very short course once it enters the thigh. So there it runs for about 2 centimeters distal to the inguinal ligament, and where it will divide, into anterior and posterior divisions. So this is the anterior division here, and this is the posterior division. So these two divisions will straddle, straddle the lateral, or they will encircle, the anterior division in front and the posterior division behind. So they are basically separated by the lateral circumflex femoral artery. So now let's look at the branches of the femoral nerve. So in the abdomen, before it enters, the thigh, so in the pelvis, it will give 2 branches. So one is the branch to the pectineus here, and here it supplies the iliacus muscle. So these are the 2 branches it gives in the pelvis before it enters the thigh. So once it enters the thigh and divides into anterior and posterior divisions, now these divisions will further give the branches. So the anterior division, you have to remember, is mainly cutaneous. So it gives 2 cutaneous branches and supplies only 1 muscle of the extensor compartment of the thigh. So there it supplies only 1 muscle. So the muscle supplied by it is sartorius. So sartorius is the only muscle supplied by the anterior division of the femoral nerve. Then it gives 2 cutaneous nerves. So one is the intermediate cutaneous nerve of thigh, and another one is the medial cutaneous nerve of thigh. So medial cutaneous nerve and intermediate cutaneous nerve. So these are the 2 cutaneous nerves given by the anterior division of the femoral nerve. Then the posterior division here. So the posterior division supplies, it gives a tweak to the hip joint. It gives a supply. So usually the nerves, any nerve will have cutaneous branches, will have muscular branches, articular branches, and vascular branches. So here the articular branch is to the hip joint. So it gives a tweak to the hip joint, and it will supply the all the extensor muscles here. So we have the rectus femoris, then vastus lateralis, vastus intermedius, and the vastus medialis. So all the 3 vastus and the rectus femoris, which together form the quadriceps femoris muscles, and that quadriceps femoris, which is the main extensor of the knee joint, that is supplied by the posterior division of the femoral nerve, and it will also supply the knee joint. It will also supply the knee joint, and then it will continue as the saphenous nerve. So this posterior division in the leg and in the foot, it will be continuing as the saphenous nerve. So saphenous nerve is the cutaneous nerve. So this saphenous nerve will give an infrapatellar branch. And then it will also supply the skin over the medial aspect of the leg. So skin on the medial aspect of leg. So this is in the leg. This was in the thigh. This was in the pelvis. So it supplies the skin over the medial aspect of leg, and it will also supply the skin of the medial side of the foot. Medial side of the foot. Medial side of foot and up to the ball of the great toe, skin, okay, ball of great toe. So up to here it is supplied by the saphenous nerve. So this is basically the cutaneous supply. So you have to remember the posterior division is mainly muscular in the thigh, okay, in the extensor supplying the quadriceps femoris, which is the extensor of the knee joint. So, and in the leg and in the foot, it is basically the saphenous nerve, which is the cutaneous nerve. So it is mainly cutaneous in the leg, along the medial aspect of the leg as well as the medial aspect of the foot up to the ball of great toe. Now let's look at the injuries of femoral nerve. So femoral nerve is commonly injured in the groin. It is actually the injuries of femoral nerve is rare, and if at all it is injured, it is usually by any penetrating wounds in the groin region. And sometimes this femoral nerve can also be compressed by the inguinal ligament, where it results in femoral neuropathy. So since now we know that it has motor supply as well as it has the sensory supply, also the cutaneous supply. So there is the loss of both this motor as well as the sensory loss. So usually it can be, as I said, because of a penetrating wound like a gunshot wound or a stab injury, okay, or sometimes also due to pelvic fracture. So the characteristic features here include, okay, so in the injury of femoral nerve, we have the motor loss. So this is basically here motor loss will be weak flexion of the thigh, okay, weak flexion of the thigh, that is mainly due to the supply to iliacus as well as the sartorius muscle, okay. So sartorius muscle and iliacus are supplied by the femoral nerve, right. Sartorius is supplied by the anterior division and branch to iliacus is given in the pelvis. So since these two muscles will be affected, what will happen? There will be weak flexion, okay, weak flexion of the thigh. Then, so there is weak flexion of thigh, and the next will be the inability to extend the knee, okay, because the quadriceps femoris is paralyzed. So there will be loss of extension of knee. So this is the motor loss, whereas the sensory loss will be along the anterior, that is because the intermediate cutaneous nerve and the anterior division will be giving the intermediate cutaneous nerve and the medial cutaneous nerve of thigh. So sensory loss will be along the anterior and medial aspect of the thigh, okay, medial aspect of the thigh, as well as the medial aspect of leg and foot, okay, up to ball of great toe. The next most common condition which we see is the femoral neuropathy because of the femoral nerve entrapment. Now femoral nerve entrapment as such is less common in the thigh, but it can be compressed by retroperitoneal tumors, okay. So here it may be compressed by the retroperitoneal tumors, okay, and it can cause the symptoms of femoral neuropathy. And another important cause for localized femoral neuropathy is diabetes mellitus. Now here, because of the nerve compression, okay, so the characteristic clinical features what we see will be the weakness, okay. So there will be weakness and wasting of the quadriceps femoris muscle, okay, weakness, and there will be wasting. So because of which there will be difficulty in walking. And because of the sensory symptoms here will be pain and paresthesia, okay. So here we will see pain and paresthesia, okay. This is along the sensory distribution. So in the thigh we will see in the anterior and medial aspect of the thigh, and along the medial aspect of the leg and the foot up to the great toe. Okay, so this is along the distribution of saphenous nerve in the leg and the foot. So these are some of the signs and symptoms which we see in the femoral neuropathy. Next, moving on to the obturator nerve. Now, obturator nerve is the nerve of the adductor compartment or the medial compartment, nerve of adductor compartment or the medial compartment of thigh. So the root value, since it begins from the anterior divisions of ventral rami of L2, L3 and L4, that is its root value. So once the nerve is formed, it will descend, okay? It will descend in the psoas major muscle. So in the abdomen, it descends along the psoas major muscle and emerges from its medial border on the ala of the sacrum. And then it passes along the lateral wall of the lesser pelvis and then passes through the, okay, so in the pelvis, it passes along the lateral wall and then it passes in the upper anterior part of obturator foramen. Okay, it passes through the foramen and then enters the adductor or medial compartment of thigh. So once it enters, okay, near the obturator foramen, it will divide into an anterior and a posterior division. So it divides into anterior and posterior division once it enters the passes through the obturator foramen. So these two divisions, they straddle, okay, they straddle the adductor brevis muscle, means they will be wrapping around the, so anterior division in front, posterior division behind will be around the adductor brevis muscle. So coming to the distribution of these nerves, so the anterior division, it will pass downwards, okay, into the thigh in front of the obturator externus muscle. So here it will supply, okay, so as it comes down, so here it will supply the hip joint. It gives a branch to the hip joint and then it also supplies the pectineus sometimes. Then it supplies the adductor longus, the adductor brevis and gracilis. Okay, so and distal to the adductor longus, it will enter, the nerve will enter the adductor canal, that is the anterior division will enter the adductor canal and it will supply, it will, okay, to the femoral artery. It also gives branch to the femoral artery. So here near the adductor canal, okay, it will contribute to the formation of subsartorial plexus also, the anterior division. And it will terminate by supplying the femoral artery. The posterior division will enter the thigh by piercing the anterior part of obturator externus, which it supplies. And then it descends behind the adductor brevis and in front of adductor magnus. Okay, so it will supply the adductor magnus as well as the adductor brevis. So in the terminal part, okay, its terminal part, it will form an articular branch which we call it as the genicular branch. So the genicular branch is basically for the knee joint. Okay. So this branch, it pierces the adductor magnus or passes through the hiatus, okay, where the femoral vessels will enter the popliteal fossa, right? So it passes through that and it runs along the popliteal vessels and supplies the knee joint. Okay, so there this posterior division will also give vascular branch to the popliteal vessels. So that is about the distribution of the obturator nerve. So its anterior and posterior divisions. So coming to the injuries of obturator nerve, okay. So the obturator nerve is commonly injured in the anterior dislocation, okay, in the anterior dislocation of hip joint. Okay, so the cause may be due to anterior dislocation of the hip joint, or it can be also during radical retropubic prostatectomy. Okay, prostatectomy. So radical retropubic prostatectomy. So in these two, in these two cases, the obturator nerve is commonly injured. So what will happen? So now we know it supplies all the adductor muscles, right? Adductor muscles it supplies. Cutaneous, it actually gives in the lower part, okay, lower part of the medial aspect of the thigh. It also supplies the skin there. So the motor loss. So motor loss will be mainly loss of adduction of thigh. Loss of adduction of the thigh. So loss of adduction of thigh. And sensory loss will be because of the little bit along the medial aspect, towardly medial aspect of thigh, which is supplied by its anterior division. Next, there is obturator nerve neuropathy. Okay, there is a condition known as obturator nerve neuropathy. So here in obturator nerve neuropathy, what happens is obturator nerve can get entrapped. Okay, so basically the entrapments of nerves causes neuropathy. So it can cause the obturator nerve may be entrapped, and that will lead to medial thigh pain. Okay, so along the medial aspect here there is pain. Okay, this is in the obturator nerve neuropathy. Okay, so you can see there is pain. So this is commonly seen in athletes. Okay, athletes with the large adductor muscles, well developed adductor muscles, it can be seen. So the surgical division, okay, in cases of spastic paralysis, okay, spastic paralysis. In case of spastic paralysis, what happens is sometimes we do the surgical division of obturator nerve. Surgical division of obturator nerve is done in case of spastic paralysis. So why is it done? To relieve the spasm. Okay, so to relieve the spasm of the obturator nerve, relieve the spasm of the adductor muscles. So in spastic paralysis, we do the surgical division of obturator nerve. And you should also remember that the referred pain, okay, in diseases of the hip joint. In diseases of the hip joint, the pain may be referred to the knee joint because of the common nerve supply there, because it supplies both the hip joint, as well as the knee joint. And sometimes, okay, the inflammation of the in females, the inflammation of the ovary causes localized peritonitis. Okay, so and this peritonitis is seen in the region of the ovarian fossa. Okay, so in the ovarian fossa, we see peritonitis because of the inflammation of the ovary, and this will cause irritation of obturator nerve. Okay, so the pain will be referred to the hip as well as to the medial side. Okay, so pain can be felt to the hip, to the knee, as well as along the medial aspect of the thigh. So that is all about the obturator nerve. So next we move on to the thickest nerve in our body, and that is the sciatic nerve. So sciatic nerve is the thickest nerve in our body. So this sciatic nerve is formed by the ventral rami of L4 to S3 spinal nerves. Sciatic nerve, it is the nerve of the posterior compartment, of thigh. So this nerve it arises in the pelvis. It arises in the pelvis by the ventral rami of L4 to S3 spinal nerves. So it leaves the pelvis. Okay, it leaves the pelvis by passing through the greater sciatic foramen. So below the piriformis here. So this is in the pelvis. We have L4, L5, S1, S2 and S3. So here the greater sciatic notch it passes below the piriformis muscle. This is the piriformis muscle and it enters the gluteal region. So here it will descend. Okay, so in the gluteal region it will descend between the ischial tuberosity and the greater trochanter of the femur along the back of the thigh and a little above, that is in the thigh, back of the thigh. Okay, so posteriorly. So there at the junction of the middle 1/3 and lower 1/3, okay, that is at the superior angle of the popliteal fossa normally. So that is the usual site. So where it will divide into its two divisions, that is the tibial component, tibial nerve. So tibial nerve and the common peroneal nerve. So it's two branches. Peroneal nerve. So this sciatic nerve, it consists of two components. Okay, one is the, when it is forms, we call them as the two components, the tibial component and the common peroneal component. So the tibial component, the root value will be of the tibial component the root value is L4 to S3, whereas the common peroneal component, the root value is L4 to S2. So here this trunk of the sciatic nerve will be having these two components. So in the thigh, okay, so all the hamstring muscles, okay, hamstring muscles include the adductor magnus, we have the semitendinosus, semimembranosus, okay, and the long head of biceps. So all of these muscles, they are supplied by the tibial component of the sciatic nerve. Only the short head of the biceps is supplied by the biceps femoris is supplied by the common peroneal component. So that is about the nerve supply in the that is the thigh region, posterior nerve supply of sciatic nerve in the posterior compartment of the thigh. So its further divisions, that is tibial nerve and common peroneal nerve, we will see it separately. So the injuries, okay, so injuries of the sciatic nerve, okay, so injuries of the sciatic nerve when we see, well, here you can see the two components. So this is the piriformis muscle, so it passes here. So this is the tibial component of it, and this is the common peroneal component. So it is supplying these are all the hamstring muscles. And this is the short head of biceps. So the motor branches of this undivided trunk, now it is supplying all the muscles of the back of the thigh. Okay, so these muscles, the hamstring muscles, the back of the thigh muscles, right? What do? They flex the knee. They cause flexion of the knee and extension of the hip. Okay, so they cause extension of the hip, flexion of the knee. And its divisions, that is the tibial. So this will be the tibial nerve. And this will be the common peroneal nerve. right? So these two nerves, so the tibial nerve, basically it will supply the muscles of the leg, okay, all the muscles which will flex the leg, as well as it will supply the muscles of the foot which will plantar flex the foot, okay. So plantar flexion, so tibial nerve basically plantar flexion and flexion of foot, plantar flexion of foot and flexion of leg, okay. So that is brought about by the tibial nerve. Whereas common peroneal, it brings about the dorsiflexion. So it supplies all the muscles of the leg which will cause dorsiflexion. Okay, just briefly I'm mentioning here, again we will see it later. The sensory here, the sensory branches of the tibial nerve, okay. So the tibial nerve sensory basically supplies the skin on the back of the calf, okay, back of the calf, medial and lateral aspect of the heel, as well as along the lateral border of the foot and the whole of the sole, okay. So whereas the sensory branches of the common peroneal nerve will supply skin on the anterolateral aspect of the leg and whole of the dorsum of the foot, except near the area where, that is at the cleft, no, where it is supplied by the deep peroneal nerve. So that is the motor and sensory supply of the sciatic nerve along with its branches, basically the branches of sciatic nerve, the sensory supply which we talked about now. So here the injury to the sciatic nerve, okay, it can be caused due to penetrating injuries, okay, so penetrating wounds. Penetrating wounds, posterior dislocation of hip, or fracture of pelvis, sometimes during hip replacement, total hip replacement, or due to faulty injection, okay, intramuscular injections which are given in that region. So that can also cause injury to the sciatic nerve. So what will happen now? Motor loss. Okay, so what do we see in sciatic nerve injury? The motor loss when we see here. So the motor loss. So what was sciatic nerve supplying? Plexus of the knee as the extensors of the hip. Okay, these muscles are affected. So because of that, there is inability to extend the hip and flex the knee. Okay, so that will be the main thing from the trunk. Then because of the tibial nerve involvement, there will be loss of all movements below the knee, and there is foot drop. Okay, there is foot drop due to paralysis of all the muscles of the leg and the foot. Okay, muscles of the leg and the foot. And this motor loss will lead to something called as the flail foot. Flail foot. So flail foot, in flail foot what happens is, it leads to great difficulty in walking. So the patient will be walking in a very high stepping gait. So we will see high stepping gait. So the sensory loss. So the sensory loss will be on the back of the thigh and the whole of the leg. Okay, whole of the leg and foot, except the area innervated by the saphenous nerve. Where was the saphenous nerve innervating? Along the medial aspect of the leg as well as the medial aspect of the rest of the sensory loss all over the leg. Okay, as well as the foot is also lost, because the cutaneous supply is both by the tibial and the common peroneal nerve there. Next is the sciatic nerve neuropathy. So sciatic nerve neuropathy, sometimes what happens, as the sciatic nerve leaves the pelvis, okay, when it leaves the pelvis, it passes through the piriformis muscle. Okay, so we see it here. So this is sciatic nerve neuropathy, which is also known as the piriformis syndrome. Sciatic nerve neuropathy. So here what happens, as the sciatic nerve leaves the pelvis, okay, it passes, sometimes it passes through the piriformis. Usually it passes through the sciatic notch, greater sciatic notch, and below the piriformis. But sometimes it can pass through the piriformis muscle, and at that point it can get entrapped, okay, and that will lead to what we call it as the piriformis syndrome. It is a very common anatomical variant. Okay, so anatomically, when we see the course of the sciatic nerve, it is a common one to see passing through the piriformis, but the entrapment, it's a very rarely the entrapment happens, but if it happens, it leads to sciatic nerve neuropathy. Then there is a very important condition which we call it as sciatica. Okay, so sciatica is a term applied to a clinical condition which is characterized by shooting pain. Okay, so there is shooting pain which is felt along the course of distribution of the sciatic nerve. Okay, so in the gluteal region, posterior aspect of the thigh, lateral aspect of the leg, dorsum of the foot, all over we feel that shooting pain. So you can see all over here there is the pain. So it occurs due to compression. So here usually the compression of the nerve, compression and irritation of L4 to S3 spinal nerves, which can be because of the herniated, okay, intervertebral disc. Okay, so this is the herniated disc which we can see here. So this herniated intervertebral disc of the lumbar vertebrae can cause compression of the nerve here, leading to the sciatica. So we can see the entire distribution here where there will be shooting pain along its course. We should also remember that the sciatic nerve is uncovered on the back of the thigh, okay, on the back of the thigh, in the angle between the lower border of gluteus maximus here and the long head of biceps femoris. At this region, okay, at the angle between the lower border of gluteus maximus and long head of biceps, this sciatic nerve is basically uncovered. Okay, it is not covered there. So because of that, what happens? There may be temporary compression of sciatic nerve. So especially when we are sitting at the edge of the chair, or when a person that is on the rod of the bicycle, okay, on the bicycle when they do a double ride, right? So when you sit on the rod of the bicycle, so it can cause a compression of the nerve, and that will result in what we call it as the sleeping foot. So basically there will be paresthesia, okay, along the distribution of sciatic nerve. So this we call it as the sleeping foot syndrome or sleeping foot. Okay, it is called as the sleeping foot. So that is about the sciatic nerve. So next we study about the tibial nerve, which is one of the largest terminal branch of the sciatic nerve. So it is the largest terminal branch. It's the largest terminal branch of sciatic nerve. So this nerve begins at the superior angle of the popliteal fossa. Okay, and it passes down in the middle of the popliteal fossa, and then it will enter the posterior compartment of the leg. So once it supplies the structures in the posterior compartment of the leg, it will enter the foot by passing through the flexor retinaculum, beneath the flexor retinaculum, and there it will divide into medial and lateral plantar nerves or branches. Okay. So here if you see the distribution of the tibial nerve, so it begins in the thigh. Okay, so in the thigh, in the popliteal fossa here. Okay, popliteal fossa. It gives mainly branches to the boundaries of the popliteal fossa. That is, it supplies the medial head of gastrocnemius, then it supplies the plantaris, the lateral head of gastrocnemius. Okay, then it also supplies the popliteus muscle, and here it gives branches to the knee joint, that is genicular branches. okay, genicular branches, and it also supplies the superior tibiofibular joint, okay, superior tibiofibular joint. Then in the leg, okay, so that is the distribution in the popliteal fossa. So popliteal fossa, it supplies the muscles, that is medial and lateral, head of gastrocnemius, the plantaris, the popliteus, and it gives articular branches to the superior tibiofibular joint as well as to the knee joint, genicular branches to the knee joint. Then in the leg it will supply soleus, okay, so all the plexus muscles there, soleus, flexor digitorum longus, the tibialis posterior, and flexor hallucis longus muscle. It gives a cutaneous branch, that is the sural nerve, which will be supplying the lateral aspect of the foot, okay, up to the little toe. It supplies along the lateral aspect of the leg, and the little toe we have the sural nerve which supplies. So there is this small branch, this is called the sural communicating nerve, sural communicating nerve. So in the sole, it mainly, after passing through the flexor retinaculum here, it will divide into medial, this is the medial and lateral branches. Medial and lateral branches. So these medial and lateral plantar nerves we will study separately, but here this is about the distribution of the tibial nerve. So what will happen if the tibial nerve is injured? So how can tibial nerve get injured? So injury of the tibial nerve can occur by a lacerated wound, mainly in the popliteal fossa, or maybe because of a posterior dislocation of the knee joint, Okay, so these are the main causes for the injury of tibial nerve. So when the tibial nerve is injured, now here we are seeing the tibial nerve in the popliteal fossa here. So if the nerve is injured there, what can happen? So motor loss. So what is the motor loss now? So motor loss, it is basically, it was supplying all the flexus of the leg, right, as well as the plantar flexus. So what will happen? The foot is held in. Foot is, because plantar flexion is lost. Plantar flexion is lost, okay. So there is loss of plantar flexion. So because of which the foot is held in dorsiflexion, okay. And there is loss of prominence of the calf muscles and the tendocalcaneus, right, because again there is paralysis of the tendocalcaneus is formed by the 𝗙𝗵𝗄𝗏 muscle, which includes the medial and lateral head of gastrocnemius and soleus. So there is the loss of prominence of calf, okay. So and tendocalcaneus, this is basically because of the paralysis of the 𝗙𝗵𝗄𝗏 muscle. Then the plantar flexion, as I already told, is lost because there is paralysis of the flexus of the ankle, and because of the loss of plantar flexion, the patient is unable to stand on the toes, okay, unable to stand on toes. Then what about the sensory loss? So the sensory loss is here, okay, along the sole and plantar aspect of the toes. So sole along the lateral aspect, because that is supplied by the sural nerve, which is branched from the tibial nerve. So plantar aspect of toes. Okay, so there is cutaneous loss. Then there is a condition known as the tarsal tunnel syndrome. Tarsal tunnel syndrome. So what is this tarsal tunnel syndrome? It occurs because of the compression. Okay, so these are all neuropathies which occurs due to compression of the tibial nerve in the osseofibrous, osseofibrous tunnel. So where is this osseofibrous tunnel? It is under the flexor retinaculum. Okay, so it can be compressed there, which leads to pain and paresthesia of the sole of the foot. Okay, sole of the foot, and usually it is more, patient feels it more during the night. Then there's one more condition which we call it as Morton's metatarsalgia. So Morton's metatarsalgia is also called as plantar digital neuroma. Okay, so this is basically, there is the formation of neuroma. There is a formation of neuroma, okay, because of pressure of the plantar. This is we see in the plantar nerves. I will be telling that again there. So due to pressure on the plantar digital nerves. So usually it will present as intermittent pain on the plantar aspect of the forefoot, usually between the third and fourth metatarsals. So that is about the injury of tibial nerve. Next we will move on to the branches of the tibial nerve in the foot. Okay, so we have the medial plantar and the lateral plantar nerve. Okay, so the medial plantar, we also call it as the preaxial nerve of the foot. Okay, so it is the preaxial nerve of foot. So next we move on to the branches of the tibial nerve. So we have medial and lateral plantar nerves, which are branches of terminal branches of the tibial nerve. So the medial plantar nerve, it is the preaxial nerve of the foot. Okay, it is the preaxial nerve of the foot. So it is the largest terminal branch. It is the largest terminal branch of the tibial nerve. So it begins deep to the flexor retinaculum and it passes forwards between the abductor hallucis. Okay, so here we have the abductor. So it passes between the abductor hallucis and the flexor digitorum brevis. Okay, this is the flexor digitorum brevis muscle. So this nerve is accompanied by the medial plantar artery on its medial side. So the root value of this is the ventral rami of L4, L5 and S1. Okay, so it consists of L4, L5 and S1 root values. So the distribution, okay, so branches and distribution if you see. So the muscular branches are given to the abductor hallucis, the flexor digitorum brevis. So the main trunk will supply these two muscles as it is passing between them. And then the flexor hallucis brevis, this is the flexor hallucis brevis. So flexor hallucis brevis is given by the first digital nerve. Okay, so this is the first digital nerve. This is first digital nerve, which is supplies along the medial aspect of the big toe, and then it also supplies first lumbrical by this second digital nerve. Okay, second digital nerve. So that is the motor supply. Cutaneous branches. So cutaneous branches, if you see here, it gives 4 digital nerves, the first, second, third and fourth. Okay, and these 4 digital nerves, they will be supplying, okay, the skin on the medial aspect of the 3½ toes, just like how we have the median nerve. Okay, it is similar to the corresponds with the distribution of the median nerve in the hand. So this supplies the medial 3½ toes, the skin over that, and each digital nerve, okay, and each of this will also supply the dorsum of the terminal, that is on the dorsal side up to the terminal phalanx, right? So that part it will supply along the nail beds there. So that is the thing. And articular branches, it will supply the joints of the metatarsals and the tarsals. Okay, so that is articular branches. Also it gives to the joints of tarsus and metatarsus. So this is all about the distribution of the medial plantar nerve. So this medial plantar nerve, sometimes we see this medial plantar nerve entrapment. So the medial plantar nerve can be compressed when it passes, okay, so when it passes deep to the flexor retinaculum or deep to the abductor hallucis. So at this point or here it can get compressed due to the repetitive eversion of the foot. Okay, the repetitive eversion of foot can cause this, especially this happens in cases of running, gymnastics, in all those people. Okay, so there it presents. So it presents with, since it's an entrapment syndrome, it will present with burning, sensation, numbness, paresthesia or tingling sensations on the medial side of the sole as well as to the along the digits. Okay, medial side of the sole and digits. And this is, since it is seen more in case of runners, we call it as the jogger's foot. Jogger's foot. So that is all about the medial plantar nerve. Next we move on to the lateral plantar nerve. So lateral plantar nerve is the post-axial nerve of the foot. So it is the smaller terminal branch of tibial nerve. It's a smaller branch of tibial nerve, and this also begins deep to the flexor retinaculum. So once it begins at the flexor retinaculum, it appears in the sole deep to the abductor hallucis. Okay, so here we will have the abductor hallucis muscle this side. So it appears deep to that, and then it passes forwards and laterally up to the base of the 5th metatarsal. Okay, so this is the base of the 5th metatarsal. So it passes up to the base of this 5th metatarsal. So as it is passing here, okay, it passes forwards and laterally here to the base. So here these nerve between the first and second layers of the muscle. So I'm reaching between the flexor digitorum brevis. Okay, so here it reaches, and flexor digitorum brevis and abductor digiti minima. Abductor digiti minima is here. It will divide. Okay, here it will divide. At that level, it will divide into that at the base of the metatarsal, right? So there it will be dividing into two, the superficial branch and a deep branch. So this is the superficial branch, and here we have the deep branch. So coming to the distribution, so from the main trunk, okay, so this is the main trunk. So from the main trunk, it gives cutaneous to the lateral part of the sole, okay. Just like how we see the median nerve and the ulnar nerve distribution, the same thing we see here. Sole is supplied by this, the cutaneous supply is by the lateral plantar nerve, whereas the medial 2/3 there, it is by the medial plantar nerve. So it gives cutaneous supply to the, so cutaneous, it is to the lateral part of the sole, okay, lateral part of sole. So this is by the main trunk, okay, the trunk itself gives this one. And trunk will give muscular branches to supply the abductor digiti minimi here, abductor digiti minimi, flexor digitorum accessoris. This is the flexor digitorum accessoris muscle. So it supplies the flexor digitorum accessoris. Then from the superficial, okay, superficial branch. superficial branch divides into two branches. So if you see here, it will divide into two branches, the lateral and the medial. So this is the lateral branch and this is the medial. So it divides into two, lateral and a medial branch. So the lateral branch will supply muscles, that is, it also gives to the flexor digiti minimi. Okay, it supplies, so superficial will divide into lateral and medial. So lateral will be supplying flexor digiti minimi brevis, then the third plantar interossei and fourth dorsal interossei. Okay, so it supplies these three muscles, the lateral branch, and it becomes cutaneous. Okay, so it also supplies skin on the lateral side of the little toe. So if you see, the lateral branch will be supplying the lateral side of the little toe. Little toe. Whereas the medial branch, it will communicate with the medial plantar nerve. This one, it will communicate with the medial plantar nerve and it will supply the skin. If you see here, it supply the skin of the fourth cleft. So here on either side of the, that is on the medial aspect and the lateral aspect of the fourth, okay, and the fifth toe. So this is the cutaneous supply is given by the medial branch. Okay, it's mainly cutaneous. Then coming to the branches of the deep. Okay, so the deep branch here will supply now altogether 9 muscles. Okay, it supplies 9 muscles. So which are the 9 muscles it supplies? It supplies the three. It supplies here, if you see, it supplies the adductor hallucis. Okay, so I'll write here. It supplies the adductor hallucis. It supplies the second, third and fourth lumbricals. First was supplied by medial. So lateral supplies these 3 and the 5 interossei. Okay, it supplies the interossei of the first 3 metatarsals. 5 interossei, that includes 2 plantar interossei and the 3 dorsal interossei. So it supplies the interossei muscles. So this is the distribution of lateral plantar nerve. So let's look at some of the lesions which I already discussed earlier about this. The lesions of the tibial nerve, injuries of the tibial nerve, as well as the branches of the tibial nerve. So first is this is the tarsal tunnel syndrome. So here you can see there is the compression in this osteofibrous canal. There is compression of tibial nerve. Okay, so this will present as pain and paresthesia. So if you see along the foot, there will be pain and paresthesia, which will become worse during the night. Then this is the Morton's metatarsalgia. Morton's metatarsalgia is also called as the plantar digital neuroma. So here if you see, there is a formation of the neuroma, okay, because of continuous compression. Okay, there occurs the formation of neuroma following pressure on the one of the plantar digital nerves. So these are the plantar digital nerves here. Okay, so on these plantar digital nerves, because of continued compression, on the plantar digital nerves, it results in what we call it as neuroma. So usually it happens just before the bifurcation of these digital nerves near the cleft. So most commonly, it affects the plantar digital nerve between the third and fourth metatarsal. Okay, so third and fourth. So you can see here, we can see. So that leads to what we call it as the Morton's metatarsalgia. So usually clinically, if you see, it presents with pain. Okay, intermittent pain is there. intermittent pain on the plantar aspect of the forefoot, usually between the third and fourth toes, metatarsals. So usually between this point we will see, okay, here the neuroma. So the neuroma is seen between them. Next, we will go to one more branch of the sciatic nerve, that is the common peroneal nerve. So common peroneal nerve, it is the smaller terminal branch. Okay, it's a smaller terminal branch of the sciatic nerve. So this will arise in the lower third of the thigh. Okay, so when we see, it arises in the lower third of the thigh, just above the popliteal fossa. Then it will run along the superolateral border of the popliteal fossa. Okay, along the superolateral border it will run, and it will pass beneath the biceps femoris. Okay, biceps femoris muscle, biceps tendon, and then it will run over the plantaris, that is in the lower aspect, runs over the plantaris and the lateral head of gastrocnemius, and there it will wind around the neck of the fibula. Okay, that is an important thing. It winds around the lateral aspect of the neck of fibula. So in leprosy and all, lepromatous leprosy, this nerve thickens and we can feel this nerve along the, this nerve is felt. Okay, so as this common peroneal nerve winds around the neck of the fibula. Okay, so in this is clinically it is very important, because in lepromatous leprosy we can feel the thickening of the nerve around the neck of the fibula. Right, and it will reach from there. It will reach the deep to the peroneus longus, and it will divide into two branches, that is the deep and superficial branch. So the motor branches of the deep peroneal nerve will supply all the muscles of the anterior compartment. Okay, so deep peroneal nerve, the motor branches will supply all the muscles of the anterior compartment of the leg, and it will supply in the dorsum of the foot, it will supply the extensor digitorum brevis muscle as well as this skin over the first cleft. Okay, whereas the motor branches of the superficial branch, okay, the motor branches from the superficial peroneal nerve, it will supply the muscles along the lateral compartment of the leg, which we also call it as the peroneal. So we will just see the distribution here now. Okay, so this is the common peroneal nerve now, common peroneal nerve. So the common peroneal nerve, so in the popliteal fossa, okay. So in the popliteal fossa, it will give a sural communicating branch. So this is the sural communicating branch. So this will communicate, okay, to the sural nerve. And then here we can see the lateral sural nerve. And it gives genicular branches, as well as branch to the superior tibiofibular joint. Okay, so these are the branches given in the popliteal fossa. Then it divides into deep peroneal and superficial peroneal. So superficial peroneal, the nerve of the lateral compartment of leg or the peroneal compartment. Deep is of the anterior or the extensor compartment of leg. So there it will supply all the extensor muscles, that is tibialis anterior, extensor hallucis longus, extensor digitorum longus, and peroneus tertius. Okay, so these are the muscles supplied by the deep branch. The superficial branch will supply peroneus longus, supplies peroneus brevis, and it will supply the skin of the lateral side of the leg. skin of the lateral side of the leg. Okay, so in the leg, the skin on the lateral aspect is supplied by the superficial branch, whereas on the lateral aspect of the foot is supplied by the sural nerve. Then comes to the anterior compartment, where it will supply the skin of the dorsum of foot, except for the first interdigital cleft, okay, between the first and second toes, except for the skin over that. Okay, it supplies the skin over the dorsum of the rest of the area. It supplies. Whereas the deep peroneal nerve, here after supplying all the anterior compartment muscles, it gives a branch to the ankle joint. Okay, and in the dorsum, this is the dorsum of foot. So in the dorsum of foot, it will supply the one muscle, that is the extensor digitorum brevis, and the skin over the first cleft. Okay, so this one will supply except for this. So that is the distribution of the superficial and deep branch of common peroneal nerve. So what happens if common peroneal nerve is injured? Okay, so the common peroneal nerve is extremely vulnerable to injury because it winds around the posterolateral aspect of the neck of the fibula. So that is a very vulnerable site or position for the nerve to be injured. Okay, so it can be injured there either by any direct trauma or fracture neck of the fibula, or sometimes when we apply a very tight plaster cast. Okay, for the fracture, when we apply a cast, then also the nerve can be compressed in that region. So what can happen? So what is the motor loss? What is the sensory loss? So if you see motor loss, okay, so what can happen in motor loss? So motor loss, what is this? Now it is supplying all the muscles of the anterior compartment, which are the extensors, isn't it? So when the this nerve supply is affected, okay, so it results in paralysis of the anterior compartment muscles, which are basically the dorsiflexus, okay, dorsiflexus of the foot. So it will result in what we call it as the foot drop. Okay, they are the dorsiflexus of the foot, the paralysis of the muscles of the anterior compartment. Then, because these extensor muscles are involved, they are basically the extensors of toes. Okay, so there is loss of extension of the toes. And loss of eversion. Loss of eversion because the everters are the two lateral compartment muscles, that is the peroneus longus and peroneus brevis. So this injury, this is the motor loss. We see foot drop because of the paralysis of the dorsiflexus. Then loss of extension of the toes because of the paralysis of the extensors of the toes, mainly the extensor digitorum longus and extensor hallucis longus. Then we also see the loss of eversion which involves peroneus longus and peroneus brevis. This is when the common peroneal nerve is injured. Sensory loss. Okay, so sensory loss here is mainly due to involvement of the cutaneous branches. So we will see over the dorsum of the foot, okay, dorsum of the foot along the lateral aspect. So if the superficial peroneal nerve is mainly common peroneal nerve, then both the branches are involved. Otherwise, if the superficial peroneal nerve is involved, then we see along the lateral aspect of the leg as well as the dorsum of the foot, except at the first interdigital cleft. Whereas if the deep branch is involved, then we see the cutaneous loss at the first interdigital cleft. Okay, so here we have to remember that when this sensory loss is involved, where the nerve supply is by the saphenous and the sural nerve, those areas are spared. Okay, so coming to the deep peroneal nerve. So deep peroneal nerve is also called, so deep peroneal nerve, we learned that it is the terminal branch of the common peroneal, one of the branches of common peroneal. So it is also called as the anterior tibial nerve. So it is basically the nerve of the anterior compartment, nerve of anterior compartment of thigh. Nerve of the anterior compartment of leg. Okay, so it also supplies the dorsum of the foot also. So this is similar to our posterior interosseous nerve, which is a branch of radial. So now this branch arises, okay, so it begins within the peroneus longus, okay, or the neck of the fibula. Its root value is anterior primary rami of L4, L5, S1 and S2. Okay. So it begins on the lateral side of the neck of the fibula, okay, beneath the peroneus longus muscle, and then it enters the anterior compartment, okay, anterior compartment of the leg by piercing the anterior intermuscular septa. So here it will be running, okay, along with the anterior tibial artery. So this is the anterior tibial artery. So along with that anterior tibial artery, it will be running in the anterior compartment of the leg. So here if you see, initially in the upper 1/3, it will lie lateral, okay, it will be lateral. Then in the middle 1/3, it becomes anterior. Then again in the lower part, it goes lateral. So because of this, okay, the course of the nerve in this way, we call it as the nervus hesitans, because it hesitates to go over to the medial side. Okay, so nervus hesitans. Okay, it's called as nervus hesitans because it doesn't cross. It just goes anterior and again comes back lateral. It doesn't go to the medial side of the anterior tibial artery. And this nerve, it will end, okay, so it passes beneath the extensor retinaculum and it will end. So here it passes beneath the extensor retinaculum and in front of the ankle, it will divide into lateral and medial terminal branches. So the lateral branch, it will supply the extensor. This is the extensor digitorum brevis muscle. It will end up in a pseudoganglion. So this is the pseudoganglion, which we see of the lateral. Okay, so it gives a medial terminal branch. So this medial terminal branch, it will run forwards and ends by supplying the skin in the first interdigital cleft. Okay, so here it supplies. So in addition to that, this lateral branch will also supply the tarsal and the metatarsal. Okay, so lateral branch will also supply the tarsal and metatarsal joints. Tarsal and metatarsal joints. Okay, so that is the course and distribution of the deep peroneal nerve. And this medial branch, in addition to the first interdigital cleft, it also gives branch to the first dorsal interosseous muscle also. So when we see the branches, okay, the muscular branches, so mainly it supplies all the four. So here we have the tibialis anterior, the extensor digitorum longus, extensor hallucis longus, as well as the peroneus tertius. Okay, so peroneus tertius. So all these four muscles it supplies, and cutaneous branch is mainly to the first interdigital cleft. So this is about the deep peroneal nerve. So let's now look at the injuries. So this is what we call it as foot drops. So foot drops, the dorsiflexus are paralyzed. Okay, so that results in foot drops. So either common peroneal nerve or deep peroneal nerve injury, both can cause the foot drop. So when we ask the patient, so this is how they cannot lift. This is, they can flex here, but here dorsiflexion is possible, but here the dorsiflexion is not possible. So this is normal. This is foot drop. Coming to next, the cutaneous innervation. So cutaneous innervation of the skin when we see, okay. So mainly along the medial aspect we have the saphenous nerve. Saphenous nerve in the dorsum of the foot, we have the saphenous nerve to the ball of the great toe. Then we have here near the first interdigital cleft, we have the deep peroneal nerve. This is the superficial peroneal nerve. Rest of the area, superficial peroneal nerve. Along the lateral aspect, we have the sural nerve. Okay, so the same thing, we can see this is the saphenous nerve. This distribution is superficial peroneal. Here we have deep peroneal, and along the lateral aspect, this is the sural nerve. So here if you see, okay, so here we have for the first two, to the lateral two, we have the lateral plantar nerve supplying, and to the medial 3.5, here we have the medial plantar nerve near the nail bed region. Up to the first distal phalanx nerve, we see this medial plantar nerve. So that is the cutaneous distribution on the dorsum of the foot. Sensory supply here on the sole of the foot. Okay, if you see the sole of the foot, here we see the medial calcaneal branch. Medial calcaneal branch of okay, so here near the heel, okay, we see the medial calcaneal branch of tibial nerve. Along the lateral aspect, sural nerve. Medial aspect, we see the saphenous nerve. Then the medial 3.5, okay, of the medial 3.5 digits plus the 3/4 or 2/3, we see the of the sole, we see the medial plantar nerve. And lateral 1/3 and lateral 1.5 digit, we see the lateral plantar nerve. This is the distribution. The same thing we are seeing here. Okay, I already told you this, but here you have to remember these 3.5 digits will be the medial plantar nerve, and this will be the lateral plantar nerve. So coming to the MCQs, a structure is seen passing under the flexor retinaculum behind the medial malleolus. The nerve among them is, okay, which is the nerve passing under the flexor retinaculum? It is the tibial nerve. In dorsum of foot, nerve between extensor hallucis longus and extensor digitorum longus. So which nerve do we see in the dorsum of the foot? Dorsum of the foot is basically supplied by two nerves, but which passes beneath the flexor retinaculum, and between these two tendons is the deep peroneal nerve. So image shows a cross mark in the lower medial quadrant of the buttock where an IM injection was given. Patient now has weakness in knee flexion and there is foot drop. So which nerve is injured here? The sciatic nerve, because weakness in knee flexion and foot drop. So it is sciatic nerve. So alright then, so that's a wrap on today's session of nerves of the lower limb. So every revision series brings you one step closer to your NEET PG dream. So alright then, that's a wrap on today's session of nerves of upper limb. Every revision brings you much closer or one step closer to your NEET PG dreams. So stay consistent, stay focused, trust your preparation. I'll see you in the next session.